Welcome, everyone, to today's concise yet comprehensive lecture on bleaching procedures in dentistry. Throughout our session, we'll cover key aspects, including the causes of tooth discoloration, treatment planning, contraindications, and alternative approaches such as microabrasion. Delving into the chemistry of bleaching, we'll explore techniques like the walking bleach method and thermocatalytic bleaching. We'll also discuss permanent restoration post-bleaching, both internally and externally, including in-office power bleaching and at-home methods. Addressing risks and complications will ensure a thorough understanding of prognosis, empowering us to deliver optimal results and radiant smiles to our patients. Let's embark on this enlightening journey together. Systemic intrinsic causes of tooth discolorations. Genetic causes. Amelogenesis imperfecta, AI, hereditary conditions associated with mutations in genes such as AMEL, ENAM, MMP20, KLK4, and FAM83H, affecting enamel structure and subtypes include hypoplastic enamel, type 1, hypomaturation, type 2, hypocalcified enamel, type 3, and hypomature/hypoplastic enamel associated with toroidontism, type 4. Enamel defects may lead to variable hypoplasia or abnormal maturation and mineralization defects, resulting in thin, soft, brittle, or discolored enamel. Discolorations may be brown or yellow, with increased susceptibility to staining and rapid wear. Bleaching attempts may offer temporary results, often used as adjunctive to restorative treatments. Resin infiltration may be an alternative to opacities in type 2 AI. Clinical appearance and enamel structure abnormalities may also result in increased sensitivity and fragility. Dentinogenesis imperfecta, DGI, and dentin dysplasia, DD, autosomal dominant genetic dentin disorders characterized by abnormal dentin structure. DI, categorized into types 1, 2, and 3, with type I associated with osteogenesis imperfecta and involving mutations in collagen type 1 encoding genes, COL1A1 and COL1A2. DD categorized into types 1 and 2, related to mutations in the gene encoding dentin sialophosphoprotein, DSPP. Patients may have weaker teeth prone to fracture, with yellow-brown, deep amber, or blue-gray discolorations and higher translucency. Bleaching treatment often ineffective, comprehensive restorative treatment challenging due to compromised tooth structure. Other hereditary diseases causing tooth discoloration. Porphyria, erythroblastosis fetalis, thalassemia, and sickle cell anemia, various hereditary diseases causing intrinsic blue, green, brown, reddish, or yellow-green tooth discolorations due to abnormalities in hemoglobin synthesis, hemolysis, or blood disorders. Disease-related causes of tooth discolorations. High fevers, experienced during tooth development ages may cause chronologic enamel hypoplasia, resulting in banding-type discolorations on tooth surfaces. Vitamin and mineral deficiencies. Rickets, vitamin D deficiency leading to white hypoplasias due to osteomalacia, characterized by developmental anomalies in bones. Scurvy, vitamin C deficiency in conjunction with vitamin A deficiency and disturbances of phosphorus uptake can cause enamel hypoplasias. Metabolic causes of tooth discolorations. Excessive fluoride exposure can lead to enamel hypoplasia and alterations in mineralized tooth structure, especially in the enamel matrix. Results in mottled appearance of teeth, with varying shades of discoloration ranging from white spots with opaque or chalky appearance to yellow or brown stains on the facial side of affected teeth. Severity of hypoplasia correlates with fluoride uptake during tooth formation. In severe cases, surface pitting of enamel may occur, without damage to the crown's shape. Related conditions, amelogenesis imperfecta, AI, or hereditary hypophemia. Contributing factors, tumors, infections, or trauma. Treatment approach varies. Moderate cases, external bleaching may suffice. Severe cases, restorative approach may be indicated. Drug-related causes of tooth discolorations. Tetracycline. Antibiotic used to treat various diseases such as urinary tract infections, chlamydia, acne, and cystic fibrosis. Widely used from the 1950s through the early 1980s. Causes gray or brown, dark stains, particularly in young children. Stains may affect the entire tooth or occur as a pattern of horizontal stripes. Manifest during tooth development when tetracycline becomes calcified in the tooth, embedding the characteristic stains in enamel and dentin. Children are susceptible to tetracycline discolorations from 0 until age 8, pregnant women advised to avoid tetracycline. Historically viewed as permanent, but some successful cases reported with bleaching techniques such as walking bleach or prolonged bleaching with carbamide peroxide. Walking bleach technique may require intentional devitalization and endodontic treatment. Today, treatments include power bleaching, veneers, or full coverage restorations for severe cases. Patients should be informed about the risks, advantages, and disadvantages of treatment options. Local intrinsic causes of tooth discolorations. Pulpal hemorrhage. Dental trauma may rupture interpulpal blood vessels, leading to interpulpal hemorrhage and release of blood components into dentinal tubules. Hemolysis of erythrocytes results in degradation of hemoglobin into globin and heme protein, containing sulfides, causing brown/reddish or black stains in surrounding dentin. Discoloration may revert if pulp survives or persist if pulp becomes necrotic. Intercorneal bleaching effective in these situations. Pulp necrosis. Chemical, mechanical, or microbial irritation of dental pulp may lead to tissue necrosis. Disintegration products from pulp necrosis may incorporate into dentinal tubules, causing discoloration proportional to the time agents remain in pulp chamber. Responds favorably to intercorneal bleaching. Pulp tissue remnants. Remnant pulp tissue left after endodontic may disintegrate and discolor tooth structure. Careful removal of all pulp tissues during treatment advised. Restorative materials. Metallic filling materials like amalgam or gold may cause discolorations. Gold fillings reduce tooth translucency and add dark hues, while amalgam fillings undergo changes over time, causing color alterations. Removal of visible metallic fillings and exchange with aesthetic materials preferred. Composite resin restorations may leak at margins, allowing discoloring agents to penetrate into tooth and dentinal tubules. Intercanal medicaments and root filling material. Various endodontic medications and filling materials may cause discolorations. Silver points, gutta percha, resorcinol formaldehyde resin paste, phenols, iodine-containing medications, and endodontic sealers containing metallic compounds may cause discolorations. Removal of completely removed materials and use of materials with minimal discoloration potential recommended. Filling and revascularization procedures. Mineral trioxide aggregate, MTA, may cause discoloration of teeth and adjacent soft tissues. Discoloring effects observed for both gray and white formulations. Regenerative endodontic therapy. Use of antibiotic paste, particularly triple antibiotic paste, TAP, containing metronidazole, minocycline, and ciprofloxacin, can lead to dark discolorations of hard tissue structure. Minocycline, a tetracycline derivative in TAP, binds calcium ions of root dentin, forming insoluble complexes and causing discoloration in teeth with both closed and open apices. Other medications inducing discolorations include corticosteroid preparations or formocrosol and iodoform-based medications. Irrigation solutions. Sodium hypochlorite can discolor dentin due to its destructive effect on erythrocytes and ability to colonize on dentin surface. Contact with chlorhexidine may form a dark brown precipitate containing parachloroaniline, requiring mechanical removal. MTAD may cause brown discoloration, possibly due to dentinal absorption and release of doxycycline. Dental caries and calcific metamorphosis/dystrophic calcification. Dental caries. Progressing caries can cause tooth discoloration. Early stages, characterized by white, opaque enamel lesions. If caries arrests, lesion may darken by taking up pigments from exogenous's, turning deep dark brown or black. Explanations for discoloration include formation of melanin or lipofuscin, Maillard reaction, melanin or food dye uptake into carious defect, or compounds diffusing ahead of bacterial penetration of demineralized dentin. Silver compounds like silver diamine fluoride used rest caries may result in dark gray or black discolorations. Glutathione biomolecule addition to silver diamine fluoride solution may minimize tooth discoloration in vitro. Calcific metamorphosis/dystrophic calcification. Calcific metamorphosis, caused by trauma, resulting duration of pulp with mineralized tissue. Rapid deposition of reparative dentin may result in yellowish or yellow-brownish discolorations, mostly affecting anterior teeth. Reparative dentin may occupy entire pulp chamber and parts of root canal system, reducing crown translucency. Endodontic therapy may be indicated depending on extent of calcification. Dystrophic calcification involves formation of calcification foci in aging pulp, usually in paravascular or perineural locations. Not expected to respond to bleaching procedures as color changes are primarily related to translucency. Thin or full coronal coverage restorations may be indicated in severe cases. Root resorption and aging. Root resorption. Cervical root resorptions can lead to pink discolorations of teeth. Granulation tissue of the resorptive defect may be visible through thin dental enamel layer, giving characteristic pink spot appearance. Treatment involves removal of granulation tissue, trichloroacetic acid, and adhesive restoration of defect. Severe cases may require surgical exposure of resorption or tooth extraction. Aging. Aging-related tooth discolorations result from physiologic process attributed to uptake of discoloring agents into hard tissue structure over time. Aided changes such as incisal wear, craze lines, or cracks facilitate easier penetration of discoloring agents. Extracorneal bleaching can partially whiten age-related stains. Extrinsic causes. Extrinsic stains are food, beverage, or smoking-related superficial stains and discolorations. Pigments from coffee, tea, smoking, or tar may cause dark, brownish discolorations. Consumption of oranges, carrots, licorice, or chocolate may lead to fooded stains. Betel chewing and areca nut use prevalent in certain populations, causing large-scale black discolorations. Marijuana also contains staining agents. Effects of staining may be accelerated or enhanced by demineralization from acidic food or poor oral hygiene. Extrinsic stains typically respond well to scaling, polishing, or bleaching. Treatment planning for internal bleaching. Assessment and diagnosis. Review patients' dental and medical histories, including family history, genetic or systemic disorders, and past/current medications. Consider history of dental or facial trauma, orthodontic, restorative, and endodontic. Perform radiographic analysis, including periapical and bite-wing radiographs, and possibly cone beam, computed tomography, CBCT. Evaluate pulpal and periapical status. Discussion with patient. Discuss potential bleaching outcomes with the patient and understand their expectations. Integrate bleaching procedures into overall treatment plan. Involve referring dentist in the conversation, if applicable. Evaluation of dentition. Assess caries prevalence and type. Evaluate plaque control and tooth surface stains. Examine type, quality, extent of existing restorations. Use transillumination to aid in finding dental decay or pulp chamber calcifications. Planning and implementation. Based on diagnosis and assessment, determine if bleaching procedures are indicated. Plan and execute bleaching procedures as part of comprehensive plan. Monitor patient's response and adjust treatment as necessary. Follow-up. Schedule follow-up appointments to assess bleaching outcomes and overall oral health. Provide maintenance instructions to ensure long-term success of bleaching treatment. Contraindications of bleaching. Unrealistic expectations. Bleaching may not achieve desired aesthetic outcome due to underlying stain issues or patient's over-expectations. Psychological or emotional concerns. Clinicians should be aware of any psychological or emotional issues the patient have with their current dental situation, advising against bleaching if not in the patient's best interest. Documentation. Findings and discussions with the patient should be well documented for legal purposes and future reference. Additional dental procedures. Patients should be informed about the need for additional procedures such as restorative, periodontal, endodontic, or orthodontic treatments to achieve desired aesthetic goals. Existing conditions. Teeth with white or brown spot discolorations may have increased contrast after bleaching. Teeth with decay, discolored or leaking older restorations may require new restore procedures prior to bleaching. Patients with severe attrition, abrasion, abfractions, erosion, caries, or insufficient restorations may experience dentin hypersensitivity, which can be exacerbated by bleaching. Underlying issues should be resolved before bleaching. Bulimia. Patients with suspected confirmed bulimia should not receive bleaching procedures. Underlying psychological condition must be resolved prior to treatment, often requiring veneers or full coverage restorations. Orthodontic treatment. Bleaching procedures should not take place 2 to 3 weeks prior to any adhesive placement of brackets for ortho treatment. Oxygen released from peroxide compounds can interfere with bonding strength of composite resins to hard tissue structure. Alternatives to bleaching. Microabrasion. Alternative for superficial irregularities and shallow intrinsic stains in enamel surface. Technique involves mixing 18% hydrochloric acid solution with fine pumice powder to form thick paste. Paste applied to stained tooth surface and rotated rubber cup in slow-speed handpiece with light pressure used to distribute paste. Liquid or sheet rubber dam placement is mandatory. Paste applied for about 5 seconds, followed by rubber cup activation for 15 seconds. Procedure repeated up to 12 to 15 times, depending on effectiveness of stain removal. Procedure terminated if stain not fully removed to avoid permanent enamel damage. Copious irrigation with water used to remove excessive paste material. Application of topical fluoride concludes procedure. Several successful long-term case reports reported. Chemistry of bleaching. Classification of tooth discoloration. Nathu classification includes 3 types. Nathu type 1, N1, chromogen binds to tooth surface, similar to stains caused by chromogenic bacteria, coffee, tea, wine, and metals. Nathu type 2, Nathu type 1 food stain that darkens over time on tooth surface. Nathu type 3, N3, colorless material binds to tooth and causes stain after chemical reaction, often due to carbohydrate-rich foods, stannous fluoride, or chlorhexidine. Mechanism of tooth bleaching involves altering light or light-reflecting properties of enamel and dentin stains, resulting in apparent whitening. Performed using peroxide compounds. Active bleaching ingredients require quick reaction with stain components, minimal reactions with oral tissues, ease of use, and acceptable shelf life. Alkaline bleach solutions may cause less demineralization damage and are less likely to penetrate the pulp. Bleaching materials should cause minimal oxidative damage to tissues. Contemporary bleaching techniques rely on oxidative processes initiated by active peroxide compounds. Here are some key components and characteristics of these bleaching agents. Hydrogen peroxide, H2O2. Simplest peroxide, a colorless liquid slightly more viscous than water. For in-office and at-home bleaching procedures. More effective at pH values close to its dissociation constant. Breaks down into oxygen and water with the help of enzymes like peroxidases. High concentrations can cause chemical burns if in contact with soft tissues. Concentrations range from 3% to 38%. Carbamide peroxide, CH6N2O3. Breaks down into carbamide and hydrogen peroxide in aqueous solution. Available in concentrations around 10% for at-home use, up to 35% for professional use. Well tolerated by the body. Used for internal bleaching. Sodium perborate, NaBO3. Available in different preparations, as a dry powder or gel. Decomposes to release hydrogen peroxide and nascent oxygen. Safer to work with and popular for intercorneal bleaching. Mechanism of action. Hydrogen peroxide and its derivatives release oxygen radicals, which break down complex pigments in the tooth structure. Resulting chemical reactions change the wavelength of reflected light, lightening the tooth's appearance. However, a shade rebound effect may occur after bleaching, caused by the reformation of double bonds in the molecules. The walking bleach technique is commonly used for internal bleaching of non-vital teeth. Here is a step-by-step clinical protocol for performing the walking bleach technique. Diagnosis and informed consent. Evaluate the etiology and origin of the stain. Inform the patient about the treatment procedures, outcomes, and potential risks. Assessment of endodontic status. Clinically and radiographically assess the endodontic status of the tooth. Consider retreatment of existing endodontic filling if necessary. Evaluation of existing restorations. Check existing coronal restorations for adat and shade. Replace defective restorations if needed. Clinical photography. Take clinical photographs at various stages of the treatment for reference. Rubber dam isolation. Use rubber dam isolation to prevent leakage of bleaching agents. Ensure a seal at the gingival margin. Preparation of access cavity. Completely remove all restorative and endodontic materials from the access cavity. Clean the cavity thoroughly and remove any undercuts. Preparation of intercorneal space. Remove intercorneal materials to just below the labial gingival margin. Clean chamber using appropriate solvents or rinsing agents. Placement of protective barrier. Place a protective layer over the root filling material to prevent further pigmentation. Ensure a minimum thickness of 2 mm. Choose materials such as glass ionomer cements or resin composites for sealing. Placement of bleaching agent. Mix sodium perborate with an inert liquid or hydrogen peroxide. Place the mixture carefully in the pulp chamber, ensuring complete coverage. Temporary filling placement. Remove excess bleaching material and place a temporary filling material with good sealing margins. Ensure adequate thickness, ideally 3 mm, of material. Removal of rubber dam and inspection. Remove the rubber dam and inspect all tissues for any irritation or leakage. Patient instructions. Inform the patient about the procedure and expected results. Instruct the patient to return for evaluation between 3 and 10 days. Follow-up and adjustment. Adjust the bleaching protocol based on the patient's response. Consider using a mix with 3% hydrogen peroxide if desired results are not achieved. Re-evaluation and further treatment. Re-evaluate the diagnosis and treatment plan if satisfactory results are not obtained after several attempts. Postoperative radiograph and definitive restoration. Take a postoperative radiograph to check for any adverse effects. Schedule placement of a definitive adhesive restoration after 1 to 3 weeks. Follow-up appointments. Schedule yearly follow-up clinical examination and radiographic evaluation. Thermocatalytic bleaching, which utilizes heat-activated hydrogen peroxide, has been advocated for its increased bleaching effect in non-vital bleaching of endodontically treated teeth. Here's how it's done. Preparatory steps. Follow the same preparatory steps as outlined in the clinical protocol for the walking bleach technique. Application of hydrogen peroxide. Instead of placing a sodium perborate/water mix, fill the pulp chamber with 30% to 35% hydrogen peroxide. Activation with heat. Apply heat using electric heating devices or special lamps, e.g., touch and heat. Superendo alpha. The heat causes foaming of the hydrogen peroxide, leading to the release of free radical oxygen. Multiple office visits. Repeat the procedure over 3 to 4 office visits for optimal results. Some protocols also advocate placing hydrogen peroxide in the pulp chamber between treatments. Temporary filling placement. Place a temporary filling following the same steps as outlined in the walking bleach technique. Care and monitoring. Take precautions to avoid overheating of teeth, periodontal ligament, and gingival tissues. Take regular cooling breaks during the procedure. Additional thermal insulation with products like Vaseline, Orabase, or cocoa butter may be used. Informed consent. Thoroughly inform the patient about the risks and potential long-term consequences associated with this technique. It's important to note that due to the increased risk of cervical root resorption with thermocatalytic, the walking bleach technique is generally considered more favorable today. If thermocatalytic bleaching is chosen, patients must be fully informed about the risks involved. The definitive restoration of teeth following internal bleaching is crucial for long-term success. Here's how it's typically done. Selection of restoration material. An acid-etched and bonded composite resin restoration is generally preferred for optimal results. For pre-existing resin composite restorations, rebonding the filling is suggested to reduce micro-leakage risk at dentinal margins after bleaching. Placement depth and base material. The restoration should be placed at a depth that provides adequate seal for the access cavity and incisal support. In situations where composite resin restoration may compromise translucency, a white base material may be placed below the resin restoration. Shade selection. Lighter shade composites are recommended for teeth with less satisfactory bleaching results. Adhesive bond strength consideration. Adhesive bond strength between glass ionomer cements and composites to dentin and enamel may be temporarily compromised after bleaching due to remnants of peroxide or free oxygen. Various remediation techniques like dehydrating agents, sodium hypochlorite application, catalases, antioxidants, and calcium hydroxide medication have been suggested to overcome this. Bonding. At least 1 week of contact with an aqueous solution is recommended to achieve adequate bonding, with optimal bonding re-established after 3 weeks. Light curing technique. Light curing of the composite resin restoration should occur from the labial aspect to reduce the risk of microleakage. Postoperative care. Regular follow-ups are essential to monitor the restoration and ensure long-term success. By following these steps, clinicians can achieve a well-sealed and aesthetically pleasing definitive restoration after internal bleaching, ensuring the long-term success of the procedure. External bleaching procedures offer various techniques for whitening teeth, both in-office and at home. In-office external bleaching. Typically administered by dental professionals, involving the application of hydrogen peroxide gels ranging from 25% to 38% concentration. Prior bleaching, thorough cleaning and polishing of tooth surfaces are performed, and the nature of the stain is evaluated. Rubber dam isolation is essential to protect soft tissues, and precautions are taken to prevent soft tissue damage. Bleaching gels may be activated by light sources such as UV lights, tungsten halogen lights, LED, or lasers, each with its own advantages and limitations. Light sources vary in wavelengths and intensity, with some requiring shorter treatment times and offering lower risks of dental trauma. LED lamps emit cold blue light, while lasers operate at specific wavelengths to activate bleaching gels effectively. Lasers require protective eyewear for both dental professionals and patients during treatment. At-home external bleaching involves the use of custom-fitted trays filled with bleaching gel, typically containing carbamide peroxide. Patients wear the trays for a specified duration each day, usually for several weeks. The concentration of bleaching gel used at home is lower than that used in office, typically ranging from 3% to 20% carbamide peroxide. At-home bleaching provides patients with flexibility and convenience, but requires consistent use over an extended period for optimal results. Both in-office and at-home external bleach methods have their advantages and considerations, and the choice between them depends on factors such as the severity of staining, patient preferences, and clinician recommendations. Power bleaching is an accelerated in-office tooth whitening procedure that utilizes xenon plasma arc curing lights or lasers. Here's a breakdown of the clinical protocol for power bleaching. Diagnosis and informed consent. Confirm that external bleaching can resolve the discolorations and inform the patient about the procedure, its outcome, and potential for rediscoloration. Clinical examination. Detect any oral pathologies, defects, or diseases. Check the quality and shade of existing restorations. Hygiene appointment. Ensure sound gingival tissues and remove calculus or plaque. Clinical photography. Photos for reference. Protective eyewear. Ensure proper eye protection for both patient and dental professionals. Prepare vitamin E capsules for emergencies. Preparation. Clean teeth with rubber cups and pumice. Retract cheeks. Apply rubber dam isolation, either liquid or heat, to prevent leakage of bleaching agents. Application of bleaching gel. Mix and apply the gel according to manufacturer's instructions. Light activation. Expose each tooth to the light source for up to 3 passes, as recommended. Gel may remain on teeth for additional time without light activation. Gel. Remove gel with wet gauze and water, then clean with pumice and rinse thoroughly. Removal of rubber dam. Remove rubber dam and any remaining materials. Rinse again and inspect tissues. Polishing and fluoride application. Polish teeth and apply neutral pH sodium fluoride gel. Patient education. Inform the patient about the procedure, potential outcomes, and post-treatment care. Advise on sensitivity management and dietary restrictions. Post-treatment instructions. Instruct the patient to avoid certain substances for a specified period to maintain results. Power bleaching offers a rapid active method for achieving tooth whitening results, but careful adherence to the clinical protocol is essential to ensure patient safety and optimal outcomes. At-home external bleaching offers patients a convenient option for tooth whitening. Here's how the process typically works. Custom tray fabrication. Trays are custom-made either at a pharmacy with crude adaptation or in a dental laboratory after impressions are taken. Professional trays ensure proper fit and delivery of bleaching agents. Bleaching gel application. Patients load bleaching gel into the tray, typically containing 10% to 22% carbamide peroxide. The tray is worn for several hours or overnight daily for 2 to 6 weeks. Tray maintenance. Patients should check the fit and smoothness of trays regularly. Apply bleaching gel into the tray before each application. Procedure monitoring. Patients wearing trays during the day may replace the gel every 2 hours. Any discomfort or irritation should prompt the patient to stop and consult the dentist. Follow-up visits. Patients using the trays during the day should visit the dentist once a 3 weeks, while nighttime users should visit every other week for 6 weeks. Success largely depends on patient cooperation and adherence to the recommended protocol. Risks include compliance issues and potential overuse of the bleaching agent. Results from at-home bleaching can last for 1 to 10 years, providing a long-lasting solution for patients. Tooth bleaching, both internal and external, carries certain risks and complications that need to be considered. Risks associated with internal tooth bleaching. 1. Cervical root resorption. Severity. External resorption is a serious complication, with rates varying depending on the concentration of hydroxide used. Etiology. Various predisposing factors, including cementum deficiency, periodontal ligament injury, or infection, may contribute. Mechanism. Hydrogen peroxide can induce a resorptive process, facilitated by inflammatory responses and acidic environments. Using sodium perborate water suspensions instead of hydrogen peroxide can minimize this risk. 2. Soft tissue damage. Chemical burns. High concentrations of peroxides, especially in liquid form, can cause burns and tissue sloughing on soft tissues. Prevention. Careful application and removal of bleaching agents, along with the use of protective measures, are crucial. Management of complications. 1. Treatment of cervical resorption. Options range from simple fillings to extraction, depending on severity. Early detection improves prognosis. Repair. Calcium hydroxide placement in the root canal space may promote reparative hard tissue formation. Restoration. Direct restorations like composite resin or glass ionomer composite compomers may be used after surgical exposure and degranulation. 2. Soft tissue protection. Prevention. Careful application, monitoring, and removal of bleaching agents are essential to prevent soft tissue damage. Emergency management. Vitamin E can help reverse strong oxidation processes on oral soft tissues and minimize damage. Patient education and follow-up. Patients should be informed about potential risks and complications associated with bleaching procedures. They should be advised to seek immediate attention if they experience any adverse effects or complications. Follow-up visits are essential to monitor progress and address any concerns promptly. Enamel and dentin damage. 1. Changes in microhardness and morphology. Peroxide components can alter enamel microhardness and morphology, as well as cementum. Peroxide alters the proportions of organic to inorganic hard tissue components. Hydrogen peroxide modifies organic compounds of dentin. Changes are not permanent and can be reduced by fluoride application during remineralization. Bleaching with hydrogen peroxide may increase demineralization in teeth with incipient caries lesions. Bleached enamel may show increased porosity and slight erosion, especially with acidic or low pH bleaching gels. 2. Inhibition of adhesive bonding. Polymerization and bonding strength of composite resins to dentin and enamel are temporarily compromised by oxygen released during bleaching. Enamel may exhibit increased porosity post-bleaching, posing a risk for leaking restorations and potential caries activity. Remedial solutions include rinsing the cavity with sodium hypochlorite, alcohol, chlorhexidine, catalase, or sodium ascorbate. Clinicians are advised to wait 2 to 3 weeks before placing definitive adhesive restorations to allow reversal of effects and removal of hydrogen peroxide remnants from the pulp chamber. Risks associated with external tooth bleaching. 1. Tissue damage due to free oxygen radicals. Concerns regarding tissue damage in oral soft and hard tissues have been raised. Free oxygen radicals may cause damage to proteins, lipids, and nucleic acids, leading to cell damage. Caution is advised regarding product quality, techniques used, and treatment rendered to minimize risks. 2. Tooth sensitivity. Hypersensitivity is an indication of inflammatory changes in the dental pulp but may not always demonstrate actual signs of inflammation. Changes in sensitivity after bleaching are usually mild to moderate and transient over a few days. The incidence of hypersensitivity increases with the frequency of changing bleaching trays. Topical fluoridation and desensitizing toothpaste may help reduce hypersensitivity after bleaching. 3. Potential pulpal damage. Hydrogen peroxide during bleaching may reach the pulp chamber via enamel defects or cracks. Active bleaching should be avoided with restorations with ill-adapting margins or exposed dentin areas. Use of desensitizers in addition to the bleaching gel is recommended to mitigate potential damage. Caution should be applied regarding children and adults due to their larger pulpal volume. 4. Gingival irritation. The most common adverse effect is gingival irritation, usually mild to moderate and resolving within a few days. Irritation may be related to soft tissue exposures to excessive bleaching gel. Gingival irritations may also result from badly adapting trays in at-home techniques. Topical anesthesia, limited movement, and good oral hygiene can aid in soft tissue healing for more severe cases. 5. Mercury release from amalgam restorations. Some studies reported increased mercury release from amalgam restorations after bleaching, particularly with carbamide peroxide. No health implications due to the induced release of mercury by tooth bleaching have been reported. Overall, while external tooth bleaching is generally safe, careful consideration of potential risks and appropriate precautions are essential to minimize adverse effects and ensure patient safety. Prognosis of bleaching. Internal bleaching. Immediate postoperative whitening results are commonly reported. In-office vital bleaching with higher concentrations of bleaching agents tends to be more effective than at-home products. Long-term follow-up studies show variable success rates, with some cases experiencing redarkening over time. Cumulative damages to the organic matrix of enamel may result in worse outcomes for patients with lighter color shades at the beginning of bleaching procedures. External bleaching. Color regressions may occur after 1 to 3 years. Short-term bleaching results may be maintained at the 1-year follow-up, but some patients may experience worse outcomes over time. Discolorations induced by trauma or pulp necrosis generally have a good prognosis, while those caused by medications or restorations may have less successful outcomes. Discoloration from restorative materials, especially those containing metallic ions, may have certain prognosis. Younger patients may have a higher likelihood of successful bleaching due to wider open dentinal tubules compared to older patients. Gray or light yellow discolorations may be easier to bleach than other types. Well-sealing composite restorations are recommended to prevent renewed discoloration.